Imagine looking at a scan that tells you your patient's cancer is, completely gone, while their blood work is just absolutely screaming that it's rapidly spreading.
Yeah, that's the nightmare scenario.
Right. And for decades, oncologists were forced to fight advanced prostate cancer in that exact terrifying blind spot. You knew the fire was burning, but you couldn't see the flames until they were, well, already consuming the forest.
Exactly, and you're just reacting at that point.
But if you step into the clinical landscape today, that dynamic has been violently disrupted. The brand new, massive 2026 ESMO Clinical Practice Guideline for Advanced and Metastatic Prostate Cancer just handed oncologists worldwide a blindingly bright flashlight.
It really did.
And ESMO, the European Society for Medical Oncology, they haven't just issued some minor update here. This is a comprehensive global rulebook that dictates a completely new reality for diagnosis, treatment sequencing, and long-term follow-up.
Yeah, and to understand the gravity of this document, we have to recognize that the entire philosophy of treating this disease has been inverted. I mean, historically, oncology often relied on a sequential, almost defensive
Right,
strategy.
a step-by-step thing.
Right. You deploy one therapy, wait for it to fail, and then try the next. But this 2026 guideline demands an intensely aggressive, mathematically precise, and highly personalized approach from day one. And it's driven by imaging and genomic technology that, honestly, borders on science fiction.
It really does sound like sci-fi. And our mission for this deep dive is to translate this incredibly dense medical roadmap into actionable insight for you.
Because it is very dense.
Very. But if you are tracking the evolution of oncology or, navigating this space yourself, you need to understand the mechanics of this paradigm shift. We are moving away from treating a generic monolithic disease and entering an era of absolute precision warfare.
We really are.
Okay, let's unpack this, starting with the most radical departure in the guidelines. And that's the new standard of care for de novo metastatic castration-sensitive prostate cancer, or MCSPC.
Right, so the shift here is profound. And just to define terms, de novo implies the cancer is already spread at the time of initial diagnosis.
Okay.
And castration-sensitive indicates it still relies on the androgen receptor axis to survive, so testosterone. The old standard was pretty straightforward. You initiate androgen deprivation therapy, or ADT, to suppress the systemic testosterone, and you just observe.
Just wait and see.
Yeah.
Yeah.
But the problem, mechanically speaking, is Darwinian evolution. I mean, by only using ADT, you're applying a single evolutionary pressure.
So the cancer just figures out a way around it.
Exactly. The cancer cells inevitably adapt. They upregulate their androgen receptors, or they even synthesize their own androgens. And that leads to clonal escape. They figure out a way to grow without the systemic testosterone.
But the 2026 guidelines effectively ban that passive approach for high-volume disease, right? Like, the new standard is triplet therapy.
That's right. Triplet therapy is the new baseline for high volume.
So you don't just use ADT. You hit the patient with ADT, plus 6 cycles of docetaxel chemotherapy, plus a third an androgen receptor pathway inhibitor, or ARPI, like abiraterone or darolutamide. You deploy all 3 simultaneously.
All at once.
It's like fighting a massive forest fire. You don't just send in one truck and wait to see if it works. You drop water from planes, send in the engines, and dig trenches all at exactly the same time.
That's a great way to look at it.
You're hitting the cancer from 3 entirely different mechanical angles before it has a single chance to adapt.
And what's fascinating here is the biological synergy of that triplet approach.
Yeah.
It's what makes it so lethal to the cancer. Because you have to think about how these drugs trap the tumor cells.
Right.
ADT removes the systemic fuel. Then the ARPI simultaneously blocks the cellular receptors from utilizing any microscopic residual fuel.
So it's starving.
Exactly. And while the cancer is hormonally starved, the docetaxel goes in and stabilizes the cell's microtubules, which physically paralyzes its ability to divide.
Wow.
The Erasons and Peace 1 clinical trials really demonstrated this. When you apply this immense multi-pathway pressure to high-volume disease, you don't just delay progression, you fundamentally alter the overall survival curve.
You're just annihilating the aggressive cellular clones before they can establish any resistance.
Exactly.
Right.
But here, the Peace 1 trial also showed us that if the disease is low volume, dropping that massive triplet therapy bomb isn't actually the optimal move.
Right, that's the catch. The guidelines dictate that for low-volume disease, you actually dial back the systemic toxicity. You use a doublet, so ADT plus an ARPI, but then you bring in targeted radiotherapy aimed directly at the primary tumor in the prostate.
And the mechanism driving that choice is really about preventing localized catastrophe.
What do you mean by that?
Well, even when the cancer has technically metastasized, treating the original primary tumor with radiation significantly delays severe genitourinary events later on. You're preventing the local architecture from collapsing. And that drastically preserves the patient's quality of life without subjecting them to the systemic toxicity of chemo when the overall tumor burden is just too low to justify it.
That makes total sense. But hitting the cancer based on its volume presents a massive mechanical hurdle, doesn't it? I mean, to treat low volume versus high volume disease differently, you have to actually see the volume.
Right, and that has always been the problem.
Which leads us into the imaging disruption. Let's look at the category of non-metastatic castration-resistant prostate cancer, or NMCRPC. A patient is on baseline ADT. Their PSA is rapidly doubling in less than 10 months.
Which is a huge red flag.
Right. The blood work is screaming that the cancer is active and resisting therapy. But when you put them in a traditional CT or bone scan, you see absolutely nothing. So it's classified as non-metastatic. But wait, if the PSA is surging, the cancer's clearly there. Aren't our cameras just not good enough? Are we just admitting that traditional imaging is blind to the reality of the disease?
This raises an important question about the limits of human perception in medicine, honestly.
Yeah.
Traditional CT scans rely on anatomical changes. A tumor has to be physically large enough to alter tissue density for the camera to capture it.
It has to be a physical lump.
Exactly. But the 2026 ESMO guidelines acknowledge that this old imaging standard was practically operating in the dark. So the mandate has shifted to next-generation imaging, specifically PSMA PIT scans.
The PSMA PIT.
Yeah. Instead of looking for a physical mass, PSMA PIT uses a radioactive tracer that specifically binds to the prostate-specific membrane antigen, which is a protein overexpressed on the surface of these cancer cells.
So instead of looking for a lump, you are deploying a molecular dye that illuminates the specific biological signature of the cancer.
Right.
Even if it's just a microscopic cluster of cells hidden away in a lymph node somewhere.
The difference in spatial resolution is just staggering. When you scan these rapidly rising PSA patients with PSMA PIT, the quote-unquote hidden cancer suddenly lights up. And this creates a profound clinical phenomenon called upstaging. The patient was never truly non-metastatic. The disease was simply operating beneath the detection threshold of 20th century technology.
That is wild.
Yeah, and because these incredibly sensitive scans are now the standard, the actual literal category of true non-metastatic CRPC is rapidly shrinking.
So if you're an oncologist looking at that rising PSA, but the old CT scan is clear, the new ESMO guidelines don't let you just wait around for the tumors to get big enough to see. You're mandated to shoot first.
Exactly. The clinical trials, Spartan, Aramis, and Prosper, they prove that waiting is a fatal error.
You can't just watch it grow.
No. For these high-risk patients, even if conventional imaging shows absolutely no spread, the guidelines require adding next-generation ARPIs. So that's apalutamide, darolutamide, or enzalutamide to their baseline ADT.
You just go after it.
Right. By attacking the microscopic disease aggressively before it manifests anatomically, you drastically improve metastasis-free survival. You're treating the biochemical reality of the disease, not the optical illusion of a clean scan.
I love that, the optical illusion of a clean scan. But eventually, Darwinian evolution kicks in again, right? The cancer is relentless.
It really is.
It mutates to survive all of these hormonal blockades and becomes metastatic castration-resistant prostate cancer, MCRPC. And at this stage, it feels like we start treating the cancer based on its zip code, like, oh, it's in the bone, and we have to start treating it based on its specific biological fingerprint.
That is the crucial pivot right there. When the disease reaches MCRPC, it has structurally altered its own biology to survive.
Okay, how so?
Well, for instance, the tumor might develop splice variants like ARV7, and that physically changes the shape of the androgen receptor so that hormone therapies can literally no longer bind to it.
Just changes the locks.
Exactly. So the 2026 guidelines recognize this by mandating comprehensive genomic testing for all MCRPC patients. You have to sequence the tumor's DNA to find its specific structural vulnerabilities.
So what are they looking for when they sequence it?
They're hunting for alterations in specific genes like BRCA1, BRCA2, MMR, PELB2, and CDK12.
Here's where it gets really interesting. Let's look at the BRCA mutations, for example. We know these genes govern DNA repair.
Right.
If a patient's tumor has a BRCA mutation, its primary system for fixing its own DNA is already broken.
If we connect this to the bigger picture, Finding that BRCA mutation is kind of like finding the exhaust port on the Death Star.
Oh, I like that.
It dictates the deployment of a very specific class of drugs called PRP inhibitors, like olaparib or talazoparib.
Okay.
The mechanism here is called synthetic lethality. Every cell has multiple pathways to repair everyday DNA damage. But if a cancer cell has a BRCA mutation, pathway A is already broken.
So it's relying entirely on something else.
Exactly. It becomes entirely dependent on pathway B, which is governed by the PRP enzyme.
So the PRP inhibitor knocks out the cancer cell's only remaining backup system. The cell is already hobbled by the BRCA mutation, and the drug just aggressively kicks that final crutch away.
That's exactly what happens.
The cancer cell's DNA simply shatters, and the cell dies, while the healthy cells, which don't have the BRCA mutation, they survive the drug just fine because their primary repair system still works.
The precision of it is just remarkable. Trials like PUFOUND and TALAPRO-2 demonstrated that combining these PRP inhibitors with an ARPI in patients with these specific genetic fingerprints, it yields profound survival benefits.
That's incredible.
And similarly, if the genomic sequencing reveals a mismatch repair deficiency, or DMMR, it means the cancer is highly mutated and visually distinct to the immune system.
So you change tactics again.
Right. In that scenario, the guidelines pivot away from hormones entirely and deploy PD-1 inhibitors, which is immunotherapy, to basically uncloak the tumor so the patient's own T cells can hunt it down.
It is the literal definition of targeted warfare. But even beyond genomic sequencing, the guidelines detail a treatment approach that takes us targeting to a subcellular radioactive level.
Yes, the radioligands.
Let's talk about the radioligand therapy, specifically lutetium-177, PSMA-617.
This brings us right back to that PSMA protein we discussed during the imaging revolution.
Right, the one the PET scans look for.
Exactly. The VISION and PSMA-4 trials prove that we can utilize that specific surface protein for therapeutics, not just for diagnostics. Lutetium-177 PSMA-617 is an engineered molecule designed to circulate through the bloodstream and bind perfectly to the PSMA receptor.
And it's carrying something.
It is. Tethered to this molecule is a highly volatile radioactive isotope.
It's essentially a radioactive homing pigeon. It bypasses the healthy tissue, finds the PSMA protein on the outside of the cancer cell, latches on, and delivers a microscopic, lethal dose of beta radiation directly into the nucleus of the tumor cell.
The sheer mechanics of delivering targeted radiation systemically, rather than beaming it externally through healthy tissue, has completely changed late-stage survival timelines.
I can imagine.
The guidelines position this for patients who have PSMA-positive lesions and have already progressed on an ARPI. But this introduces a vital, heavily emphasized warning in the ESMO document regarding cross-resistance.
Right, because if the cancer has already mutated to survive enzalutamide, giving it abiraterone next is like trying to pick a lock with a slightly different brand of the exact same key. The cancer already knows how to defeat it.
Exactly. The clinical data on cross-resistance is definitive here. Giving a patient a sequential second ARPI rarely yields a meaningful response.
Because the receptor has already changed.
Right, the androgen receptor has already mutated or developed those splice variants we mentioned earlier. So the guidelines urge oncologists not to waste precious time on therapies the cancer has outsmarted.
You have to switch it up completely.
You must radically change the mechanism of attack. If an ARPI fails, you immediately pivot to the radioactive lutetium-177, or you pivot to cabazitaxel, which is a chemotherapy that attacks the cellular structure rather than the hormonal axis.
So we have simultaneous triplet therapies, spatial resolution breakthroughs with PSMA PET, synthetic lethality with PRP inhibitors, and radioactive homing pigeons.
It's quite the arsenal.
It really is. And the direct result of this technological explosion is that patients with advanced prostate cancer are living significantly, sometimes remarkably, longer. But surviving the disease creates a totally different physiological crisis. I mean, how does a human body actually endure years of sustained biochemical warfare?
Yeah, that's the other side of the coin. And this is where the 2026 guidelines prove how holistic they really are. They dedicate an extensive, highly rigid section to supportive care, bone health, and managing the physiological devastation of these treatments.
It's not just about the tumors anymore.
Not at all. The ESMO guidelines mandate that patients receiving androgen deprivation therapy must undergo a supervised exercise program combining aerobic and heavy resistance training for a minimum of 12 weeks.
Okay, I have to play devil's advocate from the listener's perspective here.
Go for it.
If you have late-stage cancer and your body is being subjected to intense hormone starvation and cytotoxic chemotherapy, the absolute last thing you likely have the energy for is hitting the gym to lift heavy weights.
Absolutely.
Is this an actual rigid medical mandate or just oncologists offering, good wellness advice to stay active?
No, it is a non-negotiable biological necessity. Consider the physiological reality of ADT. Testosterone is the primary signaling molecule for lean mass retention and metabolic regulation in men.
Right.
When you chemically strip that away, the body undergoes a catastrophic metabolic reshaping. It causes rapid bone mineral density loss, but more insidiously, it triggers sarcopenic obesity.
What exactly is that?
It's a severe loss of functional muscle mass, coupled with a rapid increase in visceral fat, and that drastically spikes cardiovascular mortality.
So the exercise isn't about wellness, it's about providing a mechanical substitute for a lost hormonal signal.
Precisely the point. Heavy resistance training is the only mechanical trigger capable of forcing the body to retain bone density and muscle mass in a testosterone-depleted environment.
That is fascinating.
And because the structural damage is so severe, the guidelines also mandate aggressive pharmacological support. We're talking a daily calcium intake of 700 to 1,200 milligrams, at least 800 international units of vitamin D, and the required use of bone-protecting agents like zoledronic acid or denosumab.
So they're artificially strengthening the skeleton.
Yeah, these agents alter the bone remodeling process to literally harden the skeleton against the osteoporosis induced by the therapy.
Because if we aren't careful, the treatment protocol will fracture the patient's spine before the cancer ever does.
Exactly. And speaking of the spine, the guidelines outline an emergency protocol that highlights the immense vigilance required here. If a patient with bone metastasis exhibits any sudden neurological symptoms, so numbness, tingling, or weakness in the lower extremities,
Oh, wow, yeah.
it immediately triggers a warning for metastatic spinal cord compression, or MSCC.
That is the nightmare scenario, isn't it? Where a tumor on the vertebrae grows inward, physically crushing the spinal cord.
It is. The ESMO mandate requires an urgent whole-spine MRI within 24 hours of those specific symptoms appearing.
24 hours? That's incredibly fast.
It has to be. If MSCC is confirmed, it requires immediate surgical decompression or high-dose radiation. A delay of even a few days can result in irreversible, permanent paraplegia.
Wow.
So the supportive care mandates reinforce a critical philosophy. Deploying sci-fi-level targeted therapies is completely useless if you allow the host body's infrastructure to collapse beneath them.
It is a monumental undertaking from every discipline of medicine. Let's briefly recap the incredible journey we've taken through this 2026 ESMO rulebook. We started with the sheer aggressive force of triplet therapies, just overwhelming the cancer's ability to mutate early on.
Right.
We navigated the PSMA-P imaging revolution, finding microscopic disease in the dark and effectively shrinking the old non-metastatic category.
That upstaging effect.
Exactly. We explored the genetic precision of triggering synthetic lethality with PRP inhibitors, the elegance of delivering radioactive lutetium directly to the cell membrane, and we anchored it all in the rigorous mechanical necessity of resistance training and bone support.
The guidelines really reflect a medical community that has finally stopped reacting to this disease and started actively hunting it at the molecular level.
And for you listening, understanding this completely shifts the power dynamic. It transforms advanced prostate cancer from a terrifying, uncontrollable, monolithic diagnosis into a highly specific, genetically unique, and strategically vulnerable condition.
It's a completely different way to fight.
You are no longer fighting a vague shadow on an X-ray. You are fighting a specific cellular mechanism, and modern oncology has engineered a specific tool to break it.
Yeah.
So what does this all mean?
It means the era of generalized oncology is dead, honestly. It's been replaced by a hyper-personalized, data-driven continuum of care.
I want to leave you with a thought, tying back to the very beginning. For decades, the entire medical world relied on rigid, distinct stages of cancer. You were either localized, non-metastatic, or metastatic. The lines were clear. But as our next-generation imaging becomes so unimaginably precise that it can detect a mere handful of rogue cells in a lymph node, and our radioactive radioligands become perfectly targeted to hunt those single cells down, will those traditional stages of cancer eventually disappear entirely? Will the binary, terrifying labels of spread or not spread simply vanish, leaving us instead with a fluid, continuous, and highly manageable spectrum of microscopic disease?
That's the real question for the future.
We'll let you ponder that.